Good morning, everyone. It is my pleasure to introduce Dr. Trishul Siddharthan for the first grand rounds of the new academic year. Trishul earned his medical degree from the University of Miami, completed his internship, residency, and chief residency in internal medicine at Yale University, followed by fellowship training in pulmonary and critical care medicine at Johns Hopkins. He moved from Johns Hopkins to University of Miami as an assistant professor in 2020 and is currently an associate professor and director of clinical and translational research for pulmonary and critical care medicine. He is the recipient of numerous awards, including a Fogarty Global Health Fellowship and the NIH Career Mentor Development Award. He's also a fellow of both the American College of Chest Physicians and the American Thoracic Society. His research and clinical career reflect commitment to both pulmonary science and global health, and with a focus on the epidemiology and management of chronic lung diseases. He has led and contributed to studies across the world, from the United States to Uganda, where he was a Fulbright Scholar. And his work has not only advanced the science of lung disease, but also informed guidelines in health policy. On a personal note, I have known Trishul since we met at the Military Toxic Exposure Research Conference several years ago, and we have been collaborating on research into deployment-related respiratory diseases ever since. He is truly an outstanding colleague, scientist, and clinician, and today he will present on exposures and respiratory disease across the lifespan. And thank you for presenting to us today, Trishul.
Thank you for having me, Janeen, and thank you all. This is a little bit different audience than I'm used to presenting to. And certainly welcome insights, because what I'm presenting actually aims, and obviously every physician and scientist aims to shift the paradigm, but we're trying to shift the paradigm in understanding chronic respiratory disease. And so in this talk, I'll talk a little bit about sort of my hypothesis in terms of chronic respiratory disease, but also what got me here for some of the junior investigators in the audience. What I will say is, please interrupt me. Please do not hesitate to interrupt me during the slides. I will be sort of previewing a vast set of data as well as prior science. And so let me just share my screen real fast. But please do not hesitate to interrupt me. So the focus of this talk, and can you guys see my slides now?
Yes, thank you.
The focus of this talk would be exposures and respiratory disease across the lifespan. And as Janeen mentioned, I'm working currently with Tammy and Butterick and Janeen on a range of proposals related to deployment-related respiratory disease. But deployment-related respiratory disease really is one manifestation of a multifaceted range of exposures that lead to a respiratory disease. And my focus historically has been chronic obstructive pulmonary disease. So these are my disclosures. I'm not going to be talking about any of the pharmaceutical products, obviously, in this talk. But the objectives of the talk are going to be threefold. First, we'll aim to understand COPD heterogeneity, how exposures across the lifespan expose individuals or put individuals at risk for COPD. And what are the implications for diagnosis of management? And during this talk, I'm going to be focusing a lot on physiology, but obviously the underlying physiology is a result of underlying pathology and the pathologic correlates of disease. And so COPD is a heterogeneous lung disease characterized by symptoms, and so dyspnea, cough, expectoration, exacerbations, that are due to abnormalities in the airways, which I'm sure everyone in this audience is well familiar of, as well as alveolar destruction emphysema that cause both persistent and progressive airflow obstruction. And the defining characteristic, at least clinically, that we see in practice is this concept of airflow obstruction that we measure by spirometry. But COPD is really more of a syndrome of sorts. And so in 1960s, the SIBA Guest Symposium and the American Thoracic Society got together and said, we have these findings with their cough and dyspnea, these pathologic correlates, which include airway dilatation, airway inflammation, emphysema, and then these physiologic parameters, which are airflow obstruction. And they sort of slammed these together and created a diagnosis of COPD. And at that time, the major risk factor for COPD was smoking. And a lot of stuff's been sort of ascertained or learned after that point, but it was thought to be more of a homogeneous disease back in the 1960s and 70s. However, as we studied this disease more and more, there were some interesting findings. And this is a slide that's very important to pulmonologists. But on the y-axis, see if I can get my clicker out. So on this y-axis, we have symptoms or change in SGRQ. And on the x-axis, we have FEV1, and that's a parameter of lung function. It's the amount of air we can exhale in 1 second. And these are individuals that were giving salmeterol, which is a bronchodilator. And what we find is usually if you want to find a tight correlation, you want to find a bunch of dots going along this line, but we find a very scattered orientation of the scatter plot. Patient A might have an improvement in lung function, but no change in the SGRQ. And patient B can have significant changes in the SGRQ, but no change in lung function. So lung function itself is not a great correlate of how we respond symptomatically in COPD. And this is a pretty important finding. It leads us to the hypothesis, or really the knowledge now, that this is a very different disease for different individuals. And this can be explained by the pathology. And so the classic Frank Netter diagram of this pink puffer and blue boater. And so we have very distinct clinical phenotypes that are a result of distinct underlying pathology. And so some individuals might have an absence of emphysema, central lobular emphysema, paraseptal emphysema, panlobular emphysema, and we really don't have a clear understanding of why an individual may present with one clinical presentation or one distinct pathologic presentation versus another. The classic endotype, and so when we think about an endotype, it is a clear pathophysiologic process whereby an underlying disorder or aberration in the underlying biology of an individual results in pathology and then physiology. So the classic endotype is alpha-1 antitrypsin, which occurs in less than 5% of the population. And historically, we've thought about cigarette exposure as the real exposure, the real risk for developing COPD, obviously among those individuals that don't have alpha-1. But we know now that exposure is highly heterogeneous, similar to COPD across settings. And so when we look at the total global burden of COPD, about 45% is related to tobacco smoke. But as we go lower socioeconomic status, that exposure or sort of risk ratio decreases down to a third or 29%. And the other exposures include ambient air pollution, household air pollution, which I study, as well as occupational exposures. And so it's this amalgamation of exposures that really causes the vast burden of COPD globally. And the vast majority of morbidity and mortality really occur in these areas in low and middle countries, where I've devoted a lot of my efforts and interests into studying this disease. COPD in non-smokers is not unique, however, in the United States. And so you guys are lucky. You guys have a very low population of COPD up in Minnesota. And I think they're all sort of studied at UMN because you actually have a very active, robust research group over there. But certainly down here in South Florida, as well as throughout the tobacco belt, we have a good burden. We have a high burden of COPD. And we additionally have a high burden of COPD among never smokers. And so the risk factors I'm talking about are certainly not unique to the United States. So what are these risk factors, and how do risk factors across the lifespan result in the distal sequela that you all might see on pathology and we see in the clinic? And so COPD was this is a classic version of the Fletcher-Pieto diagram. And on the y-axis, again, we have lung function. On the x-axis, we have years. And so thinking about that FEV1 parameter again, the hypothesis historically was that smoking caused accelerated decline in adults, individuals. But we know now that we can have individuals that are born with lower lung function as a result of intrauterine exposures that may also have accelerated decline, or may go on to have normal lung function, or individuals that obviously have normal lung function and continue normal trajectories. And so these various trajectories for individuals can result in distal sequelae of COPD. And these trajectories are mediated by both a genetic as well as an environmental component, which I'll go into. And so historically, this is a presentation we put in for Lancet Respiratory a number of years ago that outlined the various evidence-based exposures at the time. And so intrautero micronutrient deficiencies, namely vitamin A, as well as malnutrition, have been demonstrated to result in lower lung function growth at birth, as well as smoking during pregnancies. There's a hypothetical risk of biomass fuel exposure, though a recent trial in the New England Journal of Medicine last year actually came out negative, where they randomized individuals to improve cook stoves. Fetal development begins in the 3rd to 7th week of gestation. And then week 4, the left and right primary bronchi form. By week 4 to 5, we have secondary and lobar bronchi. And there are a number of genes that regulate this tracheobronchial tree formation. And those genes are thought to be associated, A, with a risk of COPD as a result of malformation or maladaptation of these airways, but also potentially expose individuals to all these other risk factors that I talked about. And so dysynapsis is a marker that we are now focusing on in pulmonary medicine as a marker of lung development. And so in the most basic form, Smith sort of described this in 2020, dysynapsis is an imbalance of the ratio of airways to parenchyma. And so an individual A is an individual with severe dysynapsis, and individual E is obviously normal ratio of airways to lung parenchyma. And these are all thought to be a result of intrautero deficiencies or early childhood deficiencies. Smith then went on, actually, or earlier than that, determined that this anatomic variation is actually a result of genetic polymorphisms. And so polymorphism of the FGF gene results in an increased odds of about 50% for COPD overall, and a greater odds of 78% increase among smokers. And so that variation in airway tree anatomy actually results in increased susceptibility to exposures. And this is important, right? And this is important for COPD, obviously, because it's the 3rd leading cause of death globally. But it's important for a range of other conditions, including deployment-related respiratory disease. Why are some individuals more susceptible to deployment-related respiratory disease than other individuals? And so this sort of speaks to some of the genetic or biologic basis for why individuals are susceptible in populations. These individuals also had worse scores on the COPD assessment test as SGRQ. So those are those symptomatic measures I talked about in the beginning of the presentation. And what we see on the left is that aberration, the FGF gene, actually results in a loss of your medial airway. And so it is actually a minor change in airway structure. However, that change in airway structure perhaps leads to differential ventilation that makes individuals more susceptible to exposure. So as our FEV1 increases, and so we have lung function growth up to the age of 25, afterwards it's an onward decline. But things can actually result in aberration of this increased lung function growth up to the age of 25, where it attenuates our lung function at the age of 25. And so respiratory infections in childhood, poorly controlled asthma, and tobacco smoke all are associated with decreased lung function attainment, as well as exposures such as biomass fuel and tobacco-related air pollution that are hypothesized in childhood and adolescence. And then finally, in adulthood, the #1 risk factor for lung function loss is tobacco smoke, but we know now also exposure to biomass fuel, occupational exposures, and comorbid medical conditions can result in worsening lung function and increased lung function decline. So my early career actually began studying this in 2014 and 2015. And as Janeen mentioned, I spent 2 years living in Uganda under Fulbright and Afogri. And at that time, there was very minimal respiratory care in this country. And I think at one point in time, our research studies actually owned the majority of spirometers in country to diagnose COPD. Our interest at the time was just figuring out the epidemiology of chronic respiratory diseases. It hadn't been surveyed nationally in Uganda in a meaningful population-based sample. So there's Uganda on the map. And for anyone that does epidemiology, I know that there's going to be few people in the room that do this. We utilize a technique called population-based sampling. And so when we want to ascertain the prevalence of a condition, it's not about looking at how many people showed up in clinic or hospital admissions. What we need to do is actually go out to the community and randomize households. And so take a wide population survey and then randomize those individuals and then sample those individuals. And so we do population-based sampling in 25 enumerated areas in a rural area called Nakaseke, which is that big red area on the top, as well as Kampala, which is a dense urban area of Uganda. We aimed for individuals above the age of 35, and we did spirometry on these individuals. And these are examples of maps. And after this, this study was done around a number of other studies that were being conducted in sub-Saharan Africa and global setting. But after this study, there were a number of other studies that looked within Uganda as well as across the region, informing the prevalence of disease. But if you can look at this map on the left over here, we had these small compact areas or slums that we went into. And then on the right, there's these widely distributed villages where we had to basically find these huts in the middle of these villages. And what we found was a range of risk factors that are associated with both COPD and asthma in these settings, but rural setting in of itself had the highest population attributable fraction. And so these are forest plots, and down here we see rural setting had individuals in rural settings had an increased risk of COPD and had increased risk of lower risks of asthma rather. And so this rural setting resulted in sort of these differential exposures that predisposed individuals to COPD and urban settings predisposed individuals to asthma. And at the time, my hypothesis is that this was largely a result of biomass exposure. But one of the issues we have with the epidemiologic science is that all the people in rural settings use biomass and none of the people in urban settings use biomass. And so you had this differential exposure that we were not able to ascertain whether or not biomass resulted or was the risk factor for COPD. And so that led to further work. And as I discussed, our study was one of a number of studies that utilized population-based sampling. And so we collaborated with these investigators across 13 low and middle income sites in these regions, including our study, the Chronica study, as well as a number of other studies being done in South America. And what it produced was a population of about 12,396 adults. And the reason why I still talk about, this work goes back a decade, but the reason why I still talk about that work that I did a decade ago is it was really the foundation, the basis for my career thereafter. And for those in the audience that are pursuing a pathway in clinical investigation at sort of the junior faculty or the fellow level, this work actually has very meaningful impact if we think about the methods and if we think about sort of the long-term history and trajectory. And so we utilized that data from Uganda, incorporated it with data from 13 other population-based sites. We compiled a population of about 12,000 adults, where the average age was 54, about half were women, and 38% were exposed to household air pollution. And so this is where we can disentangle how household air pollution and rurality affect COPD. And we did a number of analyses. The first I'll go through is household air pollution, but then how does COPD and economic status, what is the relationship between those two, asthma prevalence, pulmonary tuberculosis, and malnutrition, which were all the sort of risk factors that we looked at or sort of hypothesized in that initial slide. And so this is just the overall COPD prevalence in our population, which was 8.8%. And these were all of our sites. And within this slide, we can find very nuanced differences in terms of the epidemiology of COPD. We find that in areas like Matlab, Bangladesh, it's up to 25%, and we have more severe disease. Whereas individuals in Kampala, where we started, the prevalence was far lower. We additionally find differential effects between men and women. And so in Tumaco, Peru, in Marcos Paz, we have an increased risk of COPD compared to men. And I'll go into some of the details of why we believe that is the case. So going back to our various risk factors, as well as what we're studying here. So first, we started off with socioeconomic status. And so low socioeconomic status is a well-known risk factor for COPD. At the time, it had not been studied in these settings, and it was primarily a result of a lack of actual population-based data. So low socioeconomic status is tied to all of those risk factors we talked to, including biomass fuel exposure, uncontrolled asthma, recurrent respiratory infections, micronutrient deficiencies, as well as malnutrition. And so what we did was created a composite index using PCA analysis. And so we looked at secondary school, household size, and household income. And we can see that in the slide, those individual components really aren't significant other than secondary school. But however, when we compare the 25th to 75th percentile, we found a 23% increase in the odds of COPD in that population. Furthermore, when we looked at body weight, it was also associated with COPD. And so on the y-axis, we have basically this diagnosis of COPD as a z-score, and on the x-axis, we have body mass, but low body mass index, namely 19.8, was basically the cutoff for COPD. And so we're finding similar experiences that we find in individual cohort studies, both based out here as well as Europe. And this was consistent across sites. And so all these various rainbow colors are our sites across the world. And we found that similar inflection point across each of the sites, which is interesting because it actually is a different cutoff than what we see in the United States, which is 221, that is commonly utilized as our cutoff for increased risk for COPD. So the big question I had, obviously going back to my initial study, was biomass fuel exposure. Biomass fuel is utilized daily among close to 3 billion households. It's utilized for cooking as well as heating. Biomass fuel, for those in the audience that don't know, include wood, burning of wood, charcoal, dung, and so it's a various range of exposures. And these are pictures from each of our sites. So Pune, Peru on the left, Dhaka, Bangladesh, MATLAB, Bangladesh, as well as Nakaseki, Uganda. And so the type of exposure as well as the concentration of exposure is really important in understanding pathology. And we can see that, things are burnt differently in these different settings. The ventilation is different in different settings. And so, back then, what we had was really self-reported data. We now have individual monitoring, and I can talk a little bit about how we're doing this in Uganda today. But back then, we really had just history of exposure. And we wanted to really delve into why we found so many differences in this figure, right? Why was COPD a heterogeneous disease, heterogeneously expressed in these various populations? And so when we look at biomass across all sites, there was a 41% increase in the risk of COPD among the individuals exposed to biomass. And there was a differential effect among women, and women were more likely to have COPD in these populations. And we believe that's likely a result of the fact that in the picture prior, women are the ones that are primarily cooking in these households. In addition, individuals exposed to biomass had more severe and symptomatic disease. And this risk increased over the lifespan. And so this was a cross-sectional study, and so we don't have longitudinal data, but what we can look is at age and decile in our population. And so that's the x-axis here, as well as the prevalence of disease. And individuals with biomass fuel exposure, that prevalence increased over time. And so this was likely a compounding exposure in this population. And this is the pathologic equivalence. And so there's been very, very few studies that have looked at biomass COPD in exclusion and also compared biomass COPD compared to cigarette smoke. We just completed a clinical trial where we aim to treat biomass COPD exclusively, right? So only included these individuals in clinical trials. Every drug that is currently on the market for COPD has excluded this population. And so every trial requires an inclusion criteria of cigarette exposure for greater than 10 years. And so when you think about the fact that 3 billion people use biomass and the majority of COPD is in these low and middle income settings, we've excluded an enormous population from study, both in terms of understanding the disease pathology as well as understanding treatments. And so this, the group here today obviously is going to be able to interpret these slides better than I do. And please correct me if I'm wrong, or the authors rather were wrong when they published this. But on the left we have CS, cigarette smoke, and on the right we have biomass smoke. And when we can see that there is differential effects in terms of goblet cell hyperplasia in the cigarette smoke. We see increased anthracosis, or rather pigment deposition, both in the walls, in the parenchyma, as well as the walls of the airways and intima of the vasculature. We have increased vascular thickness as well. And that might explain why we have different phenotypes in these populations. It might explain why we have different presentations of disease for both cigarette as well as biomass smoke-related disease. Neutrophilic inflammation in the lungs is increased in biomass or biofuel exposures. Subacute exposures likely result in T2 inflammation. We're studying this currently in Uganda. There's increased IL-8 and CSF and biomass-associated COPD. And exposure of monocyte-derived macrophages results in decreased phagocytosis of heat-killed strep pneumonia. And so these individuals may be more susceptible to infections. But we really need to understand dose-dependent relationships between air pollution and immune phenotypes. And so I was just actually on the phone. My fellow is currently based out in Uganda. He's on an F-32. But what he's interested in studying is actually looking at these dose-dependent relationships. We are doing nasal swabs to look at the transcriptome of the nasal epithelium, as well as looking at blood-based biomarkers, including PBMCs. And so the next step is really understanding beyond just epidemiologic models. What is the relationship between specific 2.5 or specific exposures, as well as the immune function and immune phenotype? So how do these various risk factors play into COPD heterogeneity, and what are the implications for diagnosis and management of disease going forward? And so this is going to be a little bit of a divergence, but something that Tammy and Janeen and I have been working on for a bit. But it is understanding how ventilation may play into ambient exposure and how that may result in increased susceptibility, as well as inform therapeutics and treatment. And so this is unfortunately a kickback to medical school. It's a slide I use for medical students. But ventilation refers to the flow of air into and out of the alveoli. And so the alveoli is the distal sac or the distal unit of the lung, while perfusion refers to flow of blood to the alveolar capillaries. And we know, going back to West's diagram, that ventilation is gravity dependent. And so the apices have higher rates of ventilation. The bases have lower rates of ventilation. It is exactly why we see increased emphysema in the apices among individuals that smoke. And then individuals with alpha-1 deficiency really have more homogeneous or diffuse, rather have more diffuse disease across the lobes of the lungs. And this is an example of how ventilation is affected in an individual with COPD. And so normal, this is a VQ scan, and so we inhale technetium. On the left, we have a normal ventilation, both posterior views and all. In the middle, we have that heterogeneous patchy opacities as a result of ventilation deficits. And variation of the distribution of airway resistance and lung compliance as a result of the underlying pathology results in disparities filling and emptying rates between these individual compartments, and as a result, heterogeneous distribution of ventilation. So the pathology of COPD results in a heterogeneous distribution of ventilation, and this can be both spatial, so the different distributions within the lungs, as well as temporal. So as the lung expands and contracts, there's differential effects on emptying of the lungs. And there's a number of physiologic correlates. We utilize something called impedance oscillometry to test this. Tammy and Janina, you've probably seen these parameters in mice. And so we can assess to what extent disease is located in the large airways versus the small airways using these physiologic techniques. And ventilation heterogeneity is a part of everyday life. Airway and vessel architecture, as we breathe in and out, can be different between the central and periphery. There's lung dependence, so ventilation and perfusion are decreased in the dependent area of the lungs. And so when we're sitting upright at the bases, when we're supine, the back of the lungs. And there's differential breathing patterns. As we breathe faster, the shift more to the zone 1, which is the apical region. Intercostal breathing, what we call forced breathing, results in regional ventilation more homogeneous throughout the lungs, and increase in zone 1, and diaphragmatic breathing results in increased basilar ventilation. So it changes breath to breath as well as day to day. And it is also a result of intra and extra thoracic anatomy. As a result of increased abdominal pressure and chest wall abnormalities, we can have differential effects on pH. So there are a range of modalities for checking or assessing ventilation heterogeneity. And on the top left is a modality called velocimetry. These are human lungs. We are able to do this also in mice. And on the right, we utilize functional MRI On the bottom left, CT with the xenon, so an inhaled isotope, and on the bottom right, SPECT-CT, which I also showed you as well, functional MRI, which is a similar paradigm to SPECT-CT. And so this is data here at the University of Miami that we recently collected. On the left are those, again, those images from Smith where they looked at changes in FGF. But this is a complex slide that can be distilled succinctly into individuals with COPD have increased heterogeneity. So what we did was we had individuals undergo SPECT-CT, so they lay in a CT scanner. We have them inhale technetium. And then what we did was we normalized that based off of segments of the lungs. So on the bottom axis, the x-axis, we have each individual segment of the lung broken up into 18 segments. And on the y-axis, we look at the counts or the amount of technetium in each individual volume that's normalized for the total number of counts in the total volume of the lungs. As you can see, these are classic manifestations of West zones of lungs. And so individuals that have lower, or these segments that are in the lower lobes have increased ventilation in the lower lobes versus in the upper lobes. However, when we get to an individual with COPD, we find an increased scatter across all lobes of the lungs, which speaks to that concept of spatial distribution. And how can that spatial distribution affect our susceptibility to exposure? And so we can go back now to look at epidemiologic study. This is Bourbeau's study using CanCold, which is a Canadian population-based study, very similar to what we did in low-income settings. But what they had in CanCold was now actual individual level exposure data based off of satellite monitoring. And so PM 2.5 is 2.5 microns of exposure particulate matter. You can also look at PM 10. You can look at micro PM, but this is the historically used correlate for exposure in a lot of settings, as well as nitrogen dioxide. And what they found was individuals compared to the lowest and upper quartiles had an increased risk of COPD down here in terms of PM 2.5 exposure, as well as decreased lung function. And the hypothesis is that this synapsis, or rather that malformation of the airway that I showed you at the beginning of this presentation, as well as aberrant ventilation in the lung, which I showed you in the previous slide, makes us more susceptible to exposures over the lifespan. And this is data that we are currently looking at with Janeen and Tammy in their lab. And so we are interested now in how exposure is related to deployment-related respiratory disease. So for those in the room, you might be aware that 2 million veterans were sort of deployed after 9/11 that were exposed over their lifetimes or over that time period in Operation Enduring Freedom and Operation Iraqi Freedom. And a number of them have come back with respiratory disease. And that respiratory disease is not singular. The classic presentation or the classic report was something called constrictive bronchiolitis, where they took veterans from Fort Campbell that had respiratory symptoms, no abnormalities on PFTs, no CT findings, and biopsy these individuals, which is very controversial. But they biopsied these individuals and found a significant proportion had findings consistent with constrictive bronchiolitis. We now know that deployment-related respiratory disease is a much, much wider disease entity and affects, results in asthma, constrictive bronchiolitis, likely will result in increased rates of COPD. And there's little understanding of why individuals sort of advanced in terms of disease categories as opposed to which individuals were susceptible. Across disease categories, including asthma, constrictive bronchiolitis, there's an increased risk of exposure compared to individuals that were not deployed at the time, that were active service, not deployed, compared to those that were deployed to these sites where these exposures were occurring. And these exposures include burn pits, so naphthalene, sand, dust, as well as burning of all these waste in these sites. So this slide on the left is the preclinical model. And so this is a wild type mouse that was exposed to extract from what is hypothesized to be from these burn pits. On the bottom left is a PBS or a control, and on the right is burn pit exposure. And so we have increased neutrophilic inflammation around the airways. Very, very similar to what I was showing earlier in the slides out of Rivera and colleagues out of Mexico. When we follow these mice to term, we have increased fibrosis of the parenchyma, fibrosis of the airways consistent with constrictive bronchiolitis. And on the top right, we can show what this looks like utilizing a technology called velocimetry. And so velocimetry utilizes X-rays to look at both the temporal and spatial heterogeneity in the lungs. And so as the lung expands and contracts, we can take series of images at a range of 15 frames per second. And we can look at both spatial heterogeneity as well as temporal heterogeneity with differences in delays in emptying and expansion of the lungs. So on the top left, we have control. On the right, we have mice exposed. On the bottom, we have histograms of something called mean specific ventilation. And so this is going to be ventilation across the lung fields. And what we can see is a left shift of lower regions of mean specific ventilation. We then wanted to assess whether or not we can utilize this similar technology in humans. So can we correlate the pathology seen in deployment-related respiratory disease with changes in both the spatial and temporal measurements in the lungs obtained by velocimetry? And so in humans, we utilized a C-arm, and so these are commonly found in cath labs across the country. And we can take a series of images in 5 locations of the lungs as individuals are breathing out normally. Then what we did was reconstructed this image to the lung basically breathing in and out in 3 dimensions. And then from there, derived biomarkers, both spatial and temporal biomarkers that resulted in about 22 combinations of features. And then we trained the model to see whether or not we can identify deployment-related respiratory disease. So this is what this looks like. On the left is inspiration, on the left, on the left is inspiration, on the right is expiration. And so as opposed to that image I showed you with COPD, which is essentially basically a geographic distribution of heterogeneity, the ability to utilize velocimetry gives us both the geographic as well as the spatial components. And this, again, is unfortunately a complex size, which I'm going to distill down. And, feel free to ask questions because, unfortunately, we were forced to put a ton of data into a very, very small space. But on the left, we have a series of essentially graphs comparing various parameters. So this is projected ventilation deficit percentage. This is an oscillometric or a temporal component of the biomarker derived. And what we did was we classified it or trained it based off of COPD, goal stage or the stage of COPD. We then looked at it for grade 1 versus grade 3 to 4. And so we first trained this model in a very well-known disease where there is ventilation heterogeneity as well as obstruction. And so utilizing these biomarkers, we were able to differentiate between control as well as COPD. And what it also did was in distinct biomarkers within this helped us classify between various stages of COPD. And so on the rightmost, we basically have the y-axis is the gold classification, the x-axis is the FEV1, and we find really good discrimination between cases in both gold 1 and 2, so the mild symptomatic cases, as well as gold 3 and 4. And this data were actually just recently published in Respiratory Research. But what we were able to do is then take those classifiers, those markers of ventilation heterogeneity, and then deploy it to DRRD. And so on the right is these classifiers based off those 22 million sort of individual biomarkers. And this is sort of this discrimination between control as well as individuals with biopsy confirmed DRCB. And so what we can see is that there are some cases that obviously fall into these various thresholds. And so it's not perfect discriminator of disease. However, the AUC was 0.86. And so this is something that will likely be deployed into clinical practice. There's a number of limitations to this approach. And so the limitations include that this was a very small sample size. Nationally, there's really only a couple hundred patients that have ever been biopsied for deployment-related respiratory disease, and this actually represents the majority of the cohort. This can actually go without saying, and it's value to this group that this was actually done in collaboration with Burn Pit 360. Tammy is one of their scientific directors, but it is also an example of how patient advocacy can help advance the field, finding these individuals involved, basically flying them in from all over the country to our various sites. And so, this will be a study that unfortunately will not be replicated. And unfortunately, it is tough to validate this because there are so few individuals that are treated or really seen as sort of a rare disease. But this approach can be utilized more broadly. And so this is now the focus of my current line of investigation, both in Uganda as well as here in the United States. And so my interest is really around how we can utilize ventilation heterogeneity, how we can combine the pathologic and physiologic correlates of disease to both predict response to therapy as well as guide therapeutic management, both surgically as well as medically. These are actually individuals with asthma. So in the top left is functional MRI. This is treatment response after giving a biologic therapy. This was actually benralizumab, which is an IL-5 receptor antagonist, which targets eosinophils. So it depletes eosinophils in the airways of individuals with asthma. And as what we can see is by day 28, we can start seeing improvements in ventilation heterogeneity among these two participants. And at 1 year and at 2 years, we see almost complete improvement or resolution in their underlying ventilation deficits. This is the Vestige study, which was actually published in this last year, was sort of aimed to understand why this was occurring. And this is likely a result of changes in underlying mucus plugging, as well as airways inflammation down here at the bottom right, that results in improved aeration of the lung. This is going to be an enormous focus in the field for chronic respiratory disease going forward for both COPD as well as asthma. We're going to likely see a change in guidelines in November for COPD, and the diagnosis of COPD will change from that initial slide I showed you to include imaging as a biomarker to really pull in the pathologic correlates. And my hope is it will eventually pull in the physiologic correlates. This is data looking at SPECT, which is also another modality that I use, and we find similar results in individuals on other biologic therapies as well. And so this is across disease class. I am currently utilizing SPECT-CT, and a number of investigators around this country are utilizing velocimetry in order to identify individuals that might benefit from endobronchial valve placement. So in distal COPD or sort of end-stage COPD, we actually take out the abnormal underperforming parts of the lungs. Previously was surgical, but now what we can do is actually go in and place a valve in these airways and cause collapse or atelectasis. There is good data to support that utilizing functional imaging, so both the temporal as well as the spatial components, can predict individuals that will respond to therapy, as well as predict negative outcomes. Jerry Kreiner's group recently published increased prediction for pneumothorax, and so that's collapse of the lung post endobronchial valve placement. And so the field is changing dramatically. For most of those in the room that certainly did med school over 10 to 20 years ago, COPD and asthma really had an amalgamation of a couple different inhalers that we played Russian roulette on in terms of what to give patients. The field has really expanded to understanding endotypes. So what are the causes of these diseases and specific precision approaches to treat these diseases? My work in the field is really around this concept of ventilation heterogeneity. Both, we're looking at this with deployment-related respiratory disease. I'm looking at this with asthma, but understanding how both the pathologic and subsequent physiologic correlates can inform precision therapeutics in these fields. So in conclusion, COPD is highly heterogeneous, both locally as well as globally. The burden of COPD among non-smokers is increasing and risk is cumulative across the lifespan. And it is very, very important. And so I'm very glad to be speaking to this group because it's important that we understand this really across specialties and disciplines. The vast majority of morbidity and mortality really occurs in settings among non-smokers. And without studying these individuals, both in terms of basic biology as well as epidemiology, we're doing a disservice to people with disease. And lastly, ventilation heterogeneity represents both the genetic as well as environmental interactions that predispose individuals to COPD. I could have not done this work without numerous people. The slide's actually not big enough to sort of hold all the individuals that did contribute to the presentation that I'm showing you today. Obviously, Tammy and Janeen, we've done a ton of work together over the past 3 years. But I will stop there and answer any questions that you guys might have.
Thank you so much. That was really interesting. I am looking to see if anyone has their hands up. Not seeing anything.
Scott may have.
Yeah, I
Thanks,
do.
Scott.
Thanks for a very interesting seminar. Can you comment about how gender may play a role in the incidence of COPD, specifically with these exposures that you're studying? Your classifier, does it work equivalently for men and women? And then some of the therapeutic approaches and the animal models.
Yeah, fantastic question. I assume it's because you also know how gender has changed, or rather COPD's changed among women historically. And so we are historically, certainly when those first Netter slides were presented, we thought about COPD, and that's the reason why all the Netter were like males. It was thought to be a disease among males because males smoked. We now know that the prevalence of COPD is sort of equivalent among men and women. Women in the United States, at least, is a result of increased uptake of smoking among women in the 90s and around that time. But also, obviously, these other risk factors are now coming into play. So the prevalence of non-smoking COPD is increasing. The prevalence of smoking related COPD is decreasing. That's not to say mortality still remains high among men, but globally, women are the ones that are predominantly exposed to cook stoves daily. The classic example was Kirk Smith. He was so Tammy talked a little bit about my thesis. My thesis was actually the history of cook stoves. And Kirk Smith went out to India and he quantified that a woman that cooked in 1974 over an open fire had the equivalent of 12 cigarettes a day of exposure in the morning, in the afternoon, in the evening. And so that can explain to a large extent why the prevalence has changed over time. The other component is estrogen. And so in the preclinical model, estrogen does have a differential effect, or rather exposures have differential effect among estrogen versus non-estrogen exposed mice. Work is still being better elucidated. I can't speak as to what extent underlying estrogen versus the exposures plays a role in terms of where we see COPD epidemiology today. But the overall epidemiology is changing pretty dramatically.
Andy?
Thanks, Janeen. Hey, Trishul. Nice to meet you. Andy,
Pleasure to meet you.
I'm a translational, anatomic, and molecular pathologist. One of the projects that I work in is actually the NIH senescence network, which is mapping spatial senescence and technically normal tissues right now, but we think about disease too in both human and mouse tissues. In your models with this spatial heterogeneity of both morphology and function, have you looked at any biomarkers that hit at senescence in there and lack of progenitor cells in those niches?
Yeah, I mean, so there's two components to that, right? And so one of the really important studies that's occurring is the NIH funded. It's similar to the lung health study, but it's called SOURCE. They're taking individuals that are smoking without abnormalities and spirometry abnormalities and following them longitudinally. We've historically lacked an understanding of the early exposures to COPD. And the problem with COPD getting them at end stage is we can't answer those questions about how does senescence interact and interplay. One of the proposals I'm looking at actually is looking at ventilation heterogeneity. And what we'll be doing is doing bronchial lavages as well as bronchial brushes in those areas, looking at asthmatics. And so my hope is that I can get to that to somehow. COPD, the bigger issue is we still don't know. I can't bronch someone today and then predict they're going to get that outcome of COPD because it's just so difficult. But in asthmatics, I hope to answer that question.
Yeah, no, I think that those are some amazing human studies, and too, I mean, with the mouse, since you can get the tissue,
that's exactly right.
Model, you can go after the biomarkers in those regions. Very cool. Thank you.
That's absolutely right.
Bharat?
Bharat Tyagarajan. It was a great talk. I enjoyed it a lot. And I work on the cardia lung study. So
of course,
I do some of the similar work that you presented. So I have two questions. One is, when it comes to biomass exposure, are we really thinking about just particulate matter exposure, or is this something beyond just particulate matter exposure?
Yeah, and that's been a huge limitation in the science because, again, those exposures, even when we study biomass, it ranges from dung to wood to charcoal. And we know based off of the pharmacokinetics, pharmacodynamics, as well as toxicology, that those exposures are very different in different individuals. This is also the big issue with deployment-related respiratory disease, and it's something that Janeen and Tammy and I have really struggled with because every single burn pit had different exposures in it, right? And there was different accelerants in terms of JP, whatever, jet fuel, naphthalene, silica, dust. So that has really plagued the field in terms of how do we link specific exposures to specific outcomes, and how do we get beyond self-reported epidemiologic data. There's been speaking about deployment-related respiratory disease, we have a black carbon silica naphthalene model. There's been another sulfur dioxide model that's also been demonstrated that have demonstrated similar pathology. But it also explains why we're having such differential disease in patients. My suspicion and hypothesis is that biomass exposure is probably a lot tighter. And so when we take individuals with charcoal or wood stove, the pathology that's related to those exposures are probably closer, more similarly aligned. But it is very much a methodologic problem in the field.
Okay. And my second question was you talked a little bit, I mean, you just mentioned that, you were starting to work on PBMCs and looking at immune responses. And one of the challenges that, we have faced is when you talk about, immune response or inflammatory responses in PBMCs, these are, well, in peripheral blood and not really in the lung.
They're not.
And is it really, and is it really reflective of what's going on locally?
It's not.
So I was just...
it's just not. I mean, in a study section, you'll get destroyed if you talk about PBMCs as a reflection of lung inflammation. It's the reason why we're bronching folks and really getting into the airways. And even with that, there's limitations, right? So the airway itself is not a reflection of what's going on in the epithelium as well as the muscle wall when diseases like asthma. But the issue is in Uganda, we did have a study which involved bronchoscopies. It is a lot more complicated, right? We don't actually have the ability. So one of my projects, which was funded by the Chest Foundation, was actually setting up a bronchoscopy lab. And we had an R21 where we were actually doing bronchs in individuals with and without HIV and COPD. But halfway through, your bronchoscopist moves, and it was the only bronchoscopist in country. It adds some additional challenge. But here in the U.S., we're certainly undertaking actual airway sampling because that is much more closely aligned to actual airways inflammation. I completely agree with you.
Thank you. Thank you very much.
I have a question. It seems like in these countries, they have an increased, or locations, they have increased carbon exposure. Have there been any studies on like the C14 content in those areas, the radioactive form of carbon?
Yeah, we actually have, so at our marine campus, we actually have the ability to do that. And we're actually taking filters. We have both gravimetric and nephelometric monitors. And so we're actually taking the filters and looking at that because there's not been a lot of work onto those specific components or exposures within those filters. People have just weighed those filters and just looked at the overall difference in mass. And so one of the projects we are doing is actually bringing those back. The investigator I work with actually looks at isotopes and Arctic ice, basically for determining like ice thickness over centuries. So yeah, I'm very interested in that. I actually am interested in your input though. I'm not entirely sure, and what I've sort of discussed with my fellows is what is the actual pathologic or rather clinical significance of that. I don't necessarily know if what I'm doing is a fishing expedition or not, but if you have additional insight, that would be super helpful.
Yeah, well, I just was thinking that the overall carbon content, because it's a naturally abundant, the natural abundance is constant, right? But I'm guessing the carbon load in these regions where they're burning biomass is going to be a lot higher than, at the power plant.
That's right.
Exactly, right. So I think if you were able to see like what the, overall, if you did controls in, like an urban population versus these populations and looked at the radioactive
That's a good idea.
footprints, right? So you should be able to, and that should be a pretty easy measurement, I would think. And I'm guessing it's gonna be a lot higher just because there's a lot more carbon in those locations.
Yeah, that's actually a very good idea. Interesting. And I actually do have symptoms that, we have symptomology and some lung function outcomes. Yeah, we actually may be able to do that. Yeah, thank you. That's actually helpful.
I was wondering if you would recommend the use of mask to individuals who are working in front of these kind of cooking.
Yeah. That's really tough. And so there's been, obviously post-COVID, it's a disaster talking about masks. But there have been, so I'll talk a little bit about some of these studies to date that have looked at air pollution interventions, because obviously if we can't get the best definition of what our host is in terms of pollutants resulting in COPD, what are the effects of interventions, which are really the terminal goal of all science. So there was a clean cook stove intervention, which basically randomized mothers in India, Kenya, Peru, and one other site to either clean cook stoves or LPG versus regular cook stoves, what they're currently using. LPG obviously reduces biomass exposures significantly. They demonstrated that the reductions were almost down to normal levels, or what's WHO recommended. The problem is that study actually was negative. And so they looked at intrauterine growth or term lung function, as well as respiratory infections, pediatric respiratory infections. That study did not demonstrate any benefit. And in fact, every study, and this was sort of my work during my thesis, every study to date has been negative in terms of interventions for reductions in air pollution in low and middle income settings. In high income settings, it's a little different. So the Clean Air Study, which was NIH funded multinational study, looked at air purifiers in home and found that susceptible individuals, so individuals with COPD, actually had improved respiratory symptoms, decreased exacerbations. And so I think masking probably aligns with that, in that masking should be recommended among susceptible individuals during periods of high exposure. We're actually actively studying with the Marine campus down here, the Saharan dust, because we have huge issues with the Saharan dust down here in South Florida as these dust plumes come over. And so I'm studying asthmatics that are exposed to Saharan dust to see whether or not it worsens symptoms. And my hypothesis is that basically among that exposed group, intervention with masks will actually reduce exacerbations and improve outcomes. But there's not a lot of really, really solid evidence to date, just because we haven't really identified the correct study population.
Okay. Are there any more questions? We're almost to the end of the hour. Nope.
Yeah, thank you all again. I mean, this was wonderful, and it's really Janeen, thank you so much. I mean, presenting the pathology actually adds a lot of value to the science and the work. So this was a pleasure.
Great. Thank you so much.